Welcome everybody to this first session of the 2021 Pediatric Days. And in this first session, we will focus on the first period of life, the neonatal period, which, as you all know, is a very crucial period for the developing child. And I must say that I'm really excited to be able to discuss this topic with all of you, with all the experts in this platform. And although it is a bit strange that I'm not seeing your faces, I know you're there. And I would also invite you to please participate, ask questions in the meeting chat as much as you like. In this session, Neonatology Back to Basic, we will concentrate on basic neonatal care with a special focus on breastfeeding, in contrast to what we discussed in earlier pediatric days. In 2016 and 2019 in Stockholm, the focus was more on technical aspects of respiratory support in neonates. And although we realize that this technical support, like incubators and CPAP, can of course be really beneficial and save lives, basic care needs to be the foundation of everything. And even though basic care sounds really basic and maybe easy, we all know that it is not, and that it is really difficult to implement it in our missions. I think you're all aware of that. So I'm really very happy to have this session because I'm a firm believer that basic care, if we do it well, can accomplish so much. And I hope that this session will inspire you to look at different ways of implementing things and look at neonatal care, basic neonatal care and breastfeeding from a different perspective. The session was prepared by a multidisciplinary group. And there were quite a lot of different people in that group. There was a nurse, there was a midwife, there was a lactation specialist, a nutritionist, an anthropologist, and of course a pediatrician. And this also reflects how we want to look at neonatal care, and especially also at breastfeeding support, like a multidisciplinary thing. What can you expect in this session? First, Professor Joy Lawn will set the scene by giving an overview of neonatal morbidity and mortality. Then we will dive into breastfeeding, which we want to approach as an intervention and not as something that is just happening by itself. Himali De Silva, lactation specialist, will tell us about breastfeeding support. And then we will see 2 videos of how breastfeeding can work in the field and the perspective of mothers and even of a father on breastfeeding. Thereafter, I'll ask Doris Borcher, a medical anthropologist, to give her anthropological view on these videos. What can we learn from this? What will still be challenges? After the presentations, you will have the possibility to discuss with the panel. And the panel discussion will be this group of speakers, including Louis Naira, a medical coordinator from MSF. And I advise you to extract as much as possible knowledge and information from these experts, so that you have the best possible starting point to make sure that you can give the best care possible on neonates and in breastfeeding support. So already during the presentations, I would advise you to start putting questions in the chat. Now I'm very honored to introduce you to Professor Joy Lawn for the first presentation. Joy Lawn is a professor of maternal, reproductive and child health epidemiology, and she is the director of the Center for Maternal, Reproductive, Adolescent and Child Health of the London School of Hygiene and Tropical Medicine. She developed the evidence base to measure and reduce newborn death, stillbirth, and premature birth, and also informs the Sustainable Development Goals. She published a lot of articles on the topic and is a leader in equitable research worldwide. We are very honored that you're here, Joy Lawn, and can I invite you to start your presentation? Thanks.
Good morning, good afternoon, good evening, everybody. It's such a privilege to be here. Thank you, Harriet, and thank you to the MSF community and partners around the world. Harriet said that I'm here as a neonatologist and as a professor, but I would say that my main qualification here today is that I was nearly a newborn death in a humanitarian context setting in northern Uganda, where my mother had an emergency C-section in a hospital with no running water and no electricity. So I salute all of you around the world, because every day you are the people who are seeing that mothers and babies survive. And in this talk, I so wish we could be face to face. I would love to meet you in Senegal and learn from you. But I also salute MSF for the way this virtual conference is being run, that it's not just on high from Zoom, but we're interacting together, and I look forward to meeting you in the network lounge later. So to move forward, we are on this platform now because of a small matter of the COVID pandemic. And I want to start by saying only 56 weeks into that pandemic, we have a massive transformation, not just in the fact that we are all working and living differently and difficultly in many ways, but also with the data and the attention we have to disease and deaths. So every day we can get an update on disease and deaths. So far, more than 135 million cases, around 3 million deaths. But what you see is the data gap too, because if you look at this chart, the confirmed cases and deaths in Africa are completely different, for example, from high-income countries. So we have, yes, faster data, but still a data gap and a data artifact. And at the same time, we've had a massive transformation in the data science. So if you feel like you're living in a tsunami of papers, we are. Almost 115,000 publications as of this week, impossible to keep up with. But what we see is not just the deluge of publications, but the transformation in the demand for science. Because it used to be that 4% of those were open access. Now 77% are open access. Newspapers are reporting science. Things have changed. We've had 30 years, for example, trying to get a group B strep vaccine. And in 1 year, we've got more than 100 vaccines for COVID. So, my friends, all of us were a baby once, but babies don't scare people. Things that scare people and affect people can pull levers for change. What can we learn? And how can we use this to transform what happens for women and babies around the world? Because within that, newborns are not the face of what happens to COVID, not directly affected, but many indirect effects. So we struggle even to measure what is happening for deaths around the world. Still, 300,000 women dying giving birth should be unacceptable. After the first month of life, still 5.1 million children dying before their 20th birthday. And what we're talking about today, 2.5 million dying in that first month of life. On the global agenda, not because the women or the families it happened to are out there complaining, not really because it's in the media, but actually because we have global goals that countries are now committed to. And we need to find ways to implement those. Still, not on the global agenda, more than 2 million stillbirths dying in the last 3 months of pregnancy. So in total, with the last data we have, 2019, more than 10 million deaths. 50% of those around the time of birth, slower progress. Africa, 13% of the world's births, and yet around 2/3 of this burden. And we have no data for how this has changed at a global scale during the COVID lockdowns. And undoubtedly, from the snapshots of data we have, things have really been challenging. So these days are focused on this pie chart and how we change it. The global causes of death for children. We have around a quarter for infections, around a quarter for chronic conditions, and more than half in the neonatal period. Yet many of us live in a pie from the past. We need to focus on what the actual causes are now. And in the global burden of disease, in every region of the world in 2019, the top condition is neonatal conditions. This is 7.3% of all disability adjusted life years. That's more than cancer, Dallies. And yet we're still not paying attention to the deaths, but also to the importance of health, a healthy start that goes on through your whole life cycle. Yet, apparently, we do have commitment. So in the Sustainable Development Goals, we have a target to end preventable child deaths. And that, for the first time, has an explicit target for newborn deaths. The exciting news is that more than 90 countries around the world are acting every day now on change for every newborn. The challenge is that in many countries around the world, more than 60 countries, we're off track to reach that target. And 40 countries, and that's particularly humanitarian contexts where MSF is working, need to more than double the rates of progress. And to do that, we need basic care and beyond. So if we look around the world at how that differs, we can see that in every region, there are green countries. So the more green these countries are, the faster their rate of progress for reducing newborn deaths. And every continent, every region has countries that are going faster. The fastest in Africa at the moment is Rwanda, overtaken Malawi. And a great way to get someone to go faster is to say, here's a competition, just like you're doing here. How do we go fast and learn from each other? But also, how do we look for those who are being left behind? And that is particularly the humanitarian context. How do we do that differently? And this is, again, something that the world has committed to. So in the Every Newborn Action Plan, every country in the world signed on to a World Health Assembly resolution. There's a specific roadmap to accelerate progress for every newborn in humanitarian settings. And I encourage you to look at that. I hope it's in the resource library, and there are 9 actions there, which include a focus on breastfeeding. And MSF have such a huge role to play in this as the biggest organization out there in the field. And yet I was surprised to see, I hadn't noted this, that MSF doesn't seem to be involved in this or in the action around this and the ongoing progress. And I'd love to hear, how MSF is partnering with these other agencies as well to really accelerate progress. So each year, 140 million babies come into the world. We all enter the world equal, naked, vulnerable. I hope we cried. And 20% of those babies are born into crisis settings, into fragile contexts. Yet 45% of the world's newborn deaths are in those humanitarian settings. And often we think of those settings as just being one particular type of context. But actually, with the changes around the world, we now have different settings. So in high-income countries even, we now have some areas of crisis, but particularly in upper middle income and lower and middle income contexts. We have both this invisible world of births at home where community care and empowering families and public health approaches are critical. We have this increasing number of births in facilities where we struggle with even the basic quality of care. And then in upper middle income countries, we have these sad situations around the world where people were used to a higher degree of care, but conflict has changed that. So you're working in all these different worlds, and knowing your context and what to do is critical. But in each of those settings, we have an evidence base and we have the basics. And we need to make sure that we do the basics well, whether that's at home, and home alone is often the reality, sometimes with a traditional birth attendant or a community worker or family workers, but also in this upper middle income context where we struggle with over-medicalization. Maybe women are not allowed into facilities. And so how do we take our context, whatever your context is, apply the evidence and make a difference? Well, one way to do that is to learn from your neighbor or from papers. Another way is to look at history. I have to say, as someone who's a fake Brit, that sometimes I worry that looking at the UK is not the thing to do anymore. But if we look at history for what happened for newborn deaths in the UK and the US, these two lines, they met this target that we want to meet of a neonatal mortality rate of 12 before 1980. But if you look at the level of neonatal mortality in Africa and Asia now, just under 30, that took about 30 years. So we are asking countries in 10 years now to 2030 to do something that took maybe 30 years. Now we have more in our hands to go more quickly. We know more about the science. We have better basis for the basics and simpler technology for the more advanced levels. But there is a level of ambition here. So how was this done in these settings? Well, if we look back at history, there was a first phase of public health measures, clean, safe birth and the basics. Then there was a phase of improving obstetric care, care at birth, and the basic things for newborns. And then there was the special care or more intensive care. All of these phases are important, but you will fail if you jump to phase 3 and you haven't got the basics in place. So we need the foundations, but we need to build to the future, because if we stop with the basics, we won't have the impact we need. And so we also need to learn from what failed in the past. And what failed was we weren't safe enough. So as we add, especially the more intensive care, we need to make sure, for example, that our oxygen use is safe, or we will generate an epidemic of blindness by not doing safe care. So looking at basic care, and we'll be hearing a lot more about this, we have this mismatch where we know what those basics are. We have a lot of evidence about them: breastfeeding, clean cord care, keeping babies warm, yet often we fail to do it. And then if we think about putting more of that together, including innovations that have come from the Southern Hemisphere and are now being rolled out around the world, kangaroo mother care is really an important innovation. And yet it takes major behavior change in the structure of a unit and in how things are run. We can close this survival gap. MSF has been a wonderful voice for many of the inequities around the world. This is one of the worst. If you're a baby who is preterm, born in a low and middle income country, maybe less than 10% survival. In a high income country, more than 90%. If we were to close this gap, we could save 750,000 babies each year. We are able to do that, and we need to move forward. There's a whole lot more attention now on what to do for small and sick newborns. WHO has just brought out these standards of care. There's an implementation toolkit, which we would love MSF to be involved with, which Nest 360 is leading. And the reason we need this, and if the video clip could be played, is because one at a time will not be newborns. We need to be able to put together the basic care and more than one device at a time, focused on families and enabling mothers and also fathers and grandparents to play a role to save these newborns. That baby is called Chikonjetso. Chikonjetso means the conqueror. And I want to conclude by saying that every baby around the world should have a chance to be a conqueror, to be like Chikonjetso, to survive despite being preterm. To do that, we need more than one thing at a time. Yes, we can have the device, but if the baby is cold or not fed, that baby will not survive. We would love from Nest 360 Consortium, which I'm part of, if we could partner with MSF. How could we adapt some of this technology and approaches to be able to save more newborns where newborns are dying most? Thank you, MSF. We have an opportunity to transform the outcomes for every newborn everywhere, including in humanitarian settings. How can we do that? Know your data, know your context, know what works. Basics are the foundation, but if we don't go beyond, we won't reach the targets we need to. Partnerships are critical, and we would love to do more with you. And I look forward to getting to know many of you and hope that we can work together to change the future for the world's newborns. Thank you.
Thank you very much, Joy. This was really brilliant. And it shows so much the need for action, especially in the countries where MSF works. There's still so much to do, but we can really have an impact.